Yeah, welcome to this webinar. We're going to talk about a special treatment that's called Cognitive FX. This treatment is meant for people with concussion and who have severe complaints after that. And this treatment is developed in America, in Utah. And there's a lot of talk about this treatment in the Netherlands, and that's why we organized this webinar about it. We have a very special guest today, and that's Alina Fong. Welcome. She's from America, she's from the clinic, and she applied this treatment to a lot of people already, also people from the Netherlands. And we're going to have a talk with her. We have a second guest, and that's Rosanne Koster. She's participating online. And she's a doctor herself, and she had a mild stroke a few years ago. And she has gone to, she went to Utah for this treatment, and she will talk about her experiences. And then we have a third guest sitting on the table, Monique Lindhout. She's director of Hersenletsel.nl, a patient association for people with brain injuries and their families. Welcome all. First, we're going to have a look at a video. I'm starting now, and after that, we will discuss this topic. Let's see, I have to start the video.
Cognitive FX is a clinic that specializes in treating patients with post-concussion symptoms, or PCS. At Cognitive FX, we do advanced imaging, multidisciplinary therapies, and other treatments that have been scientifically proven to help our patients to recover from their post-concussion symptoms. Some of these therapies that we do in our clinic are cognitive therapies. After reviewing scan data from the patient's Fmri, we choose specific cognitive therapies that target areas of their brain that are underperforming. These therapies test and push patients' abilities, such as memory, word retrieval, and attention, to grow and reactivate pathways in their brain that have been inactivated from their concussion. Neuromuscular therapies. Our trained staff of neuromuscular therapists help our patients to rework and retrain muscles that could be affecting their autonomic nervous system or preventing brain regions from performing correctly. Using the same Fmri data, we determine the specific therapies that could help reduce or resolve the post-concussion symptoms that the patient is dealing with. Our neuromuscular therapists also walk patients through physical exercise in order to activate and prepare the brain for the specific mental activities that are performed in the other therapies. Occupational therapies. Our occupational therapists help patients to restore skills and performance they have lost from their concussion. The Fmri data, again, guides our therapists to determine the specific therapies that would benefit them in their recovery. This can include basic vision tracking and handling multisensory activities if indicated by the Fmri and the patient's symptoms. Our therapists guide the patients to set and accomplish goals that help them recover from the lingering symptoms from their concussion. These therapies, as well as many others, are performed on-site in our clinic by a multidisciplinary team, creating a streamlined and highly effective process.
We're going to have a talk about this subject with, first of all, Alina Fong. This treatment is meant for people with post-concussion syndrome. Is it not meant for people with a mild stroke or brain damage?
Well, the vast majority of our patients are patients with mild traumatic brain injury or concussion. However, we have seen some patients that have had more severe and moderate traumatic brain injuries. But yes, mainly for those with concussion. And actually more recently, we're seeing quite a few patients with long hauler post-COVID symptoms.
Okay. And what kind of symptoms does your patients have?
Oh, they have a variety of symptoms. Usually after their brain injury, they have some physical symptoms, whether it be balance issues, headache, neck pain. We have patients with some cognitive symptoms, usually memory issues, focus, attention, brain fog, feeling very tired, this brain fatigue that can occur. Then sleep issues are very common. Sometimes patients get too little sleep, sometimes too much sleep, a combination. Sometimes they can have difficulty falling asleep or staying asleep or both. And then also
all kind of symptoms.
Oh, yes. And sometimes, most importantly, is the emotional side as well. You have patients that have never before struggled with some of these depression issues or anxiety, and now after their concussion, they're really feeling down and even sometimes suicidal.
Yeah. And for what symptoms does your treatment work best?
It's that is a really good question. We feel that the cognitive symptoms, the sleep issues, the emotional issues can be taken care of usually within the week. Sometimes the headaches as well. But there are definitely some issues and some symptoms that could take a little longer to resolve, like vision issues, sometimes some balance issues as well.
And how do you explain that some people who have concussion have no symptoms at all, and other people have severe symptoms?
I don't know how to explain that.
What's your vision on that?
No, in all honesty, I rely on research and data that has been collected that looks at certain risk factors. So there are definitely some risk factors that we look at and that we screen for that are correlated with more complicated symptoms, more chronic symptoms, and harder recoveries. And some of those risk factors can be a prior medical history, that can be significant, prior psychiatric history, prior history of learning challenges and learning disabilities, etc. So there are definitely some things that might lead you down one path to chronic symptoms versus another.
Yeah, but how do you qualify for such a treatment?
Well, in order to qualify, each patient they actually fill out a questionnaire, some medical history online.
Online, okay.
Yes, and they have a consultation with me or one of the other doctors, and we go through some of the screening criteria. It's a pretty involved consultation, and at the end of that consultation, I can determine, or we can determine if we think they're going to be a good fit.
So it does not fit for everyone?
No.
With concussion problems?
No, it does not, especially when you have some patients that, want help with maybe something other than concussion or COVID, or for example, if they're struggling with other things that maybe we can't help. We don't accept everyone. I'd say about 15% of patients or people that we have a consult with, we do not allow in. Yeah, they don't fit.
Yeah. And suppose you are struggling for years with severe problems. Is treatment still possible after 2-3 years, for example?
Oh yes. In fact, our average patient is about a few years post their injury.
Oh, really?
Yeah. The reason is because most of the time, that patient is trying very hard within their own community, locally, to get all the care that they need. So I would say our typical patient comes to us about 2 to 3 years post their injury. Now, with that being said, we have had patients that have been struggling for decades.
You can't say the faster the better.
That was one of my original hypotheses. I thought that the sooner we got them in, the better. But the data shows that it doesn't matter how long ago you had your concussion, you can still improve. Neuroplasticity can remain intact. You can tap into that even decades after your injury.
Let's talk about the treatment itself. What are the building blocks of the treatment?
Ooh, okay. I like to see our treatment as kind of an archway. And the foundation of that archway is our principles of prepare, activate, and rest. And we actually published this theory about 2018. And what this talks about is in order for us to make changes in the brain, we first have to prepare the brain. So there needs to be some sort of cardiovascular reactivation. We get the patients exercising, we get their heart pumping, we get some, blood up to that brain.
To a certain level?
That is a good question. We try to we determine where that patient's kind of optimal heart rate would be. And we tried to stay within that level, but then we also tried to, in a supervised way, try to push them a little bit more and a little bit more. One of the big symptoms that our patients have is exercise intolerance, right? So we try to prepare the brain, we try to prepare the body, and we even ask patients to try to do a little bit of exercise before they come in, because the more you can do on your own, the more ground you can make with us. So prepare. The next is activate, which is the active therapies that we do, whether it be the physical therapy, the neuromuscular therapy, cognitive therapy, occupational therapy, and so on. And then the third part of that foundation is rest. We have to destimulate.
Relax.
We have to relax, you know. So that's kind of the foundation. When you look at this archway, we see that Fmri is kind of the stone that holds the
that's
archway
where you start
together.
with,
That's the
Fmri.
keystone. Yes. So the main ingredients would be that prepare, activate, rest, and the keystone that holds everything together for us is the neuroimaging piece, which guides and directs all the different treatment modalities. I like to say that we're interdisciplinary and multimodal.
But can you analyze an fMRI on a level of one person?
And that is a very loaded question. Yes, you can. And I can go into a bit more detail with that if you'd like. So some of the criticisms that we have faced is that Fmri is not generalizable and not does not have utility on an individual level. And that actually is only true if you do not understand Fmri research and statistics. If you have the correct model, if you use the correct statistics, if you have a large enough database, then yes, you actually can utilize Fmri on an individual level. And when I say enough data, you know, we have seen over 5,000 patients. We have over 30,000 Fmri scans on concussion patients. That is more data than anyone has in the world on concussions. When you have that much data, we actually can start looking at patterns and activation patterns, which actually allowed us to create these biomarkers, which we actually published as well. And so for people that have that criticism, I always say read our research. And we know the limitations of Fmri, but if you do your statistics correctly and you have enough data, it's absolutely applicable. Second part of that question too is that we are comparing each patient to themselves. So for example, Rosanna, who's here, she knows that she actually had her first Fmri before treatment. And then after treatment, she had another Fmri. So we're actually comparing those scans to the same patient. It's her own scans being compared to itself.
How long does this treatment take? Because I heard just a week in Utah, and then afterwards you have to train at home.
So for the most part, it's about 1 week. For many of our Dutch patients, I will always say, be flexible because it is much harder for you to get there than it is for even the average American. And I don't want you to be at the end of your week and say, I love it. I don't want to leave. I don't want us to have a scan at the end and have a few more things to work on, but we can't because you have to go home quickly. So I think on average, the Dutch patient usually has about maybe a week and a couple days of treatment. And sometimes it's 2 full weeks.
Okay. And how long does it take? How long does it take at home to do the training afterwards? Is there an average or?
I don't even know if there's an average, What I do know is that patient compliance is difficult. It's hard, especially for patients that leave our clinic feeling really, really good. Half of them are like, yes, I want to keep continuing to do this. And I want to continue to get better, and they'll be very compliant. And about the other half are like, I feel great. I don't want to do any of this, But I say typically it takes about 3 months post-treatment before patients start to feel 90+% better.
90+.
Yeah, I mean, and that's just some of the data that we've collected.
Okay. How's this training structured? What kind of exercises do people do?
Ooh, that is...
For example, take day one. What do they on day one?
Well, so on day one, and I know this because my colleague Amy, she is one of our head schedulers, and she and I work together to schedule. So I know exactly what patients do on day one. But a lot of it, let me explain it this way. On day one, typically the patient will get their scan, and then they have their scan reviewed by one of the doctors. And then we are able to, I take a bit more time and I make sure that the therapies that they have are exactly what they need. I do the best I can before they get their scan, just based on what I'm hearing them say. But I wait for final changes until I see that scan.
So it's a very personalized training for everyone.
Absolutely.
Yeah.
So they usually have, so the first day is a lot of assessments and evaluations. So they're going to neuromuscular therapy, and they're having an evaluation. They're doing cognitive evaluations. They're doing occupational therapy. We're looking at how their eyes are moving, balance evaluations. So that first day is really a lot of information gathering, but we're also looking at them. Every session is
just observing the people.
It's a chance to observe if they're getting tired. What is causing their symptoms to come about. So yes, a lot of assessment and evaluation, and then usually at that point, the second day is even more diving into the actual therapy. Now, a lot of the individualization, most of the individualization, is occurring within each individual therapy session that they're having. Our therapists are so knowledgeable. They are so well trained. I think we have the best in the business, right? I'm biased, but you can ask our patients as well. I mean, they really are wonderful, but they each know how to read the Fmri, and they know how to use their tools and their toolkit to apply that to that individual patient's scan.
How many patients from Holland, from the Netherlands, did you train in this way? Give you this treatment?
I knew you were going to ask that, so I made sure I knew. About 2 weeks ago, when you asked me for this information, it was 476.
Okay, so many.
But at this point, I think we're closer to 500.
Okay, and have you figures about how many people are really helped by this training?
Yes, we track patients longitudinally. We are very accountable to our patients, right? Because if they don't feel good, they call us and they let us know. Yeah. But I think, our percentages are around about 85% of our patients after the first week report feeling about 65% better. And that's subjective report. That's them saying, yeah, I feel about 65% better. That's about 85. Now, there's 15% left over. Some of those 15% feel 100% better, and some of them feel 30% better. I can count on one hand, honestly, how many patients have honestly left the clinic saying, I hate this, I feel worse. But there are definitely those, and we try to help those as best we can, but a vast majority of these patients leave us feeling better.
Nice figures.
Pretty impressive figures, if I do say so myself.
Yeah. But there is also criticism. And in Netherlands, there's a lot of discussion about this treatment. And I have some basic critics, which I like to talk with you about. First of all, it's not an evidence-based treatment. So there's not scientific randomized study results about this treatment. How do you comment on that?
Okay, I have some comments on that. So there is a difference between randomized controlled trials, and of course, evidence-based treatment. All the therapists that we have in our clinic are licensed professionals, and there's no disputing that physical therapy, cognitive therapy, occupational therapy, psychotherapy, vision, vestibular therapy, that those are not absolutely evidence-based useful for patients with traumatic brain injury. I can assure you, any rehab hospital, even here in the Netherlands and everywhere else, you have those therapists. Yeah. So the treatment we're doing is no different. It's just more specific to higher functioning individuals with more mild traumatic brain injury. Mm-hmm. Now to talk about randomized controlled trials, I fully accept as a gold standard. But we are not a research institution. We never have been. We never will be. We are a small little clinic that is treating patients on the front line. So there are cases where an RCT is not feasible, is not able to be done. Mm. So we will never be doing an RCT, mainly because there's some ethical questions about if a patient's coming to see us, can I ethically put that patient in a sham treatment and then put another one in a real treatment? I can't. Yeah. Secondly, it'll be very clear what real treatment is compared to what sham treatment would be. So it wouldn't be a blind study. Yeah. But that doesn't mean that the outcome research that we have published and we have out there isn't very useful. I mean, I think that for many of the patients that we see, the outcome data that we have is so much more pertinent to them than whether or not we've published a randomized controlled trial. I leave it to someone else to do that for us, and I believe they are doing it, starting to do it.
Are there already initiatives for a random scientific study, randomized?
I think that there are some pilot studies that are being done, and there's definitely some early studies that are looking at what it is we're doing in Utah and what elements of that could potentially be brought here that could help. Yeah.
I will talk about this with you, Monique. Some care professionals in Holland say it's all a placebo effect. What's your comment on that?
So, first of all, I've actually heard from other professionals, that placebo is not necessarily a bad thing.
No, I don't think so.
And I do think that I've actually seen that even in an initial consultation with a patient. For example, just being able to look at them and have them tell me their issues, and for me to validate them, I've seen lights go on in their eyes. I've seen them say, wow, I already feel a little lighter, is that placebo effect? It might be. And secondly, with regards to placebo effect, I think that the critics who are stating this do not fully understand what placebo effect is. So just by definition, placebo effect is having someone feel better after a dummy treatment or a sham treatment. We are anything but a sham treatment, and so there isn't this fake or dummy treatment that is occurring that's making them feel better. Again, you can ask Rosanna. There was nothing about her treatment that was fake or sham or dummy. They are feeling better because they're doing the hard work. Yeah. So I think that term is absolutely just not applicable to what we do.
And there are also doubts about the use of the Fmri. Is it also possible, do you think, that you train yourself in a hard way without this Fmri?
I think we've proven that there are definitely elements of what we do that will help concussion patients without the Fmri. So, for example, we opened up a sister clinic in the U.S. called Neural FX, and we opened it up at the best time we possibly could, which was January of 2020. right before the pandemic, right? Because who knew that was going to happen, right? And this is a clinic that's actually not imaging based, all insurance. So this is for patients that have just been injured, so more of the acute versus the post-concussion, and insurance-based, and for everyone without imaging. And we have been able to grow that clinic exponentially since we opened it, because we're offering, I call it CFX Lite. Now, again, we're working with more of the acute, so just newly injured patients. But the goal was to try to intervene at an early point, so there's less people getting PCS, right? The chronic part of this. So I know because of that success that there are definitely elements of what we do without the imaging that would be helpful. However, for patients that are much more chronic, that are more complicated, I do believe that is where the imaging is absolutely necessary, because that is really the recipe by which we utilize all these ingredients that guides the treatment. Fmri is not treatment, it just guides our therapists in order to do the best we can for that patient.
Okay. Yeah, thank you for this part, for your insight in cognitive effects. I'd like to go to our second guest and give her the stage, and that's Rosanne Koster. She's online. She's watching this webinar. She's a doctor herself, and she got a mild stroke a few years ago, and went to Utah for a treatment. And she wants to tell her story about that. I'll make the picture a little bit bigger. Hello, Rosanne.
Hello. Thank you for inviting me.
Yeah, the stage is yours.
Yes. Well, so I'm a general practitioner in the Netherlands, and in 2018 I had a small stroke. I had aphasia, and even though my words came back quite quickly, I kept having symptoms like having trouble finding the right words, concentration, attention, focus, brain fog, fatigue, and a lot of sensitivity to light and noise. And these symptoms made it very difficult for me to get back to my regular life, being a GP, being a mom. And even though I had a really good rehabilitation team here, I had a lot of very nice and good professionals that helped me. They gave me tips, and I learned things about how to deal with my symptoms. But even after a year, I still had a lot of symptoms, and I couldn't really get back to my regular life, like things like cooking or just taking care of my children, doing groceries. Those kind of things were really, really hard for me. And I decided to go to Cognitive FX. I had some doubts about it before I went, especially because a lot of the medical professionals in the Netherlands are so critical of the treatment, especially a couple of years ago. But for me, I didn't really have anything to lose, and I decided to go for it. And even if it wouldn't help me, I thought at least I can get a little bit closer to acceptance. So I went there. I went on my own, and I had the scan in the week prior to my treatment week, and I did the EPIC treatment. And my first therapy day was a full day of therapy, because I already had the scan, and it was very hard, very difficult. And after my first day, I was completely knocked out, and I just wanted to sleep. And on day 2, I had another full day of therapy, and then on day 2, I said in the evening, I thought, oh, I'm going to go for a walk, which was amazing to me. And on day 3, I actually felt like myself again. For more than a year after my stroke, I hadn't felt like myself, and then I felt like myself. I could concentrate. The therapies at Cognitive effects were a lot easier from that point on. After that, it just went uphill. And in the months after cognitive effects, I trained at home and I completely got back to my regular life. I didn't have any of the difficulties that I had before, and I actually got back to working as a GP almost full time. So it was an amazing thing. So it really changed my life.
That sounds like an incredible story. What do you think were the working elements in this treatment?
For me, I think the combination of doing the exercise, I was already exercising. I did all through my rehabilitation. I did work out, but the exercise was different than that I did, and it really helped me to get some focus in my head, making it more better possible to do the treatments, and also just the intensity of the treatments, which were very different from treatment in the Netherlands. Because in the Netherlands, we are focused more on learning how to deal with the symptoms. So if you're having problems with your memory, you learn how to make lists and how to keep track of things so that you don't forget them. And at Cognitive FX, you're actually gonna train your memory very intensive in a multitask way, which is so different. And for my character, it really worked to actually be able to train and to work hard for getting those results.
Do you think that your character is playing a part in this success of a treatment?
Yes, I think my character is actually playing a part in why I had a lot of symptoms continue, because I'm someone who is finding it difficult to take enough rest. So that was probably one of the things that was making it hard for me to get back to my regular life. And then at Cognitive FX, I could use those traits that I have to work really, really hard. And then instead of it being something that was holding me back at Cognitive FX, I could use it to let it work for me, and also in the training afterwards.
And what do you think about the comments in the Netherlands, for example, about this treatment? And people, they say it's all placebo effect.
I do think that there is. I think first of all, I think there's a part of a nocebo effect with the Dutch treatment. So in rehabilitation treatments in the Netherlands, they are quite quickly to focus on accepting and compensating. And then for people who have a concussion, they don't even get to go to the rehabilitation treatment. So they will be told, yeah, there's nothing we can do about it. So there's a nocebo effect, which means that people, if they hear they cannot get better, there's nothing they can do, they will believe that about themselves. So I think there's a nocebo effect here. And then I think there's a small placebo effect with Cognitive FX, which is actually what Alina said, being heard, being able to work on getting better. But I absolutely believe that just the intensity of the treatment is an element that works.
And how long did you train when you came home? You had this treatment for 5 days in Utah, or for 2 weeks?
I did 5 days of therapies, and I did my Fmri before. And then when I came home, I started training right away. And I did it for the first week. I trained 5 times a week, and then I went back to 3 times a week, and I did that for about 3 months. And by that time, I was already working again a lot of hours. So I actually had my cognitive training at work, doing a lot of multitasking there. I did about 3 months of training.
And are you totally recovered at the moment?
Yes, I feel like I totally recovered. I do, however, get a bit tired a bit more quickly than I did before I had my stroke, but also there are a lot of other factors that play in that. I don't have any of the other symptoms anymore.
Sounds good. How happy you must be to have your normal life back.
Yes, it was amazing, and it was amazing for me and for my family, and also a lot of the colleagues that I work with were very critical of me going there, being like a medical tourist. But when I came back and when they saw how different my life was and how different I was when I was talking to them, how I could speak more quickly, I had more energy, and all of my colleagues and everyone around me also noticed the difference. So a lot of my colleagues were a lot less critical after they saw how I recovered.
And do you have a message for all your colleagues or maybe the professional in Holland?
Yes, I would love for the rehabilitation for acquired brain injuries in the Netherlands to be more active, to be more activating in all of their therapy. And I would love everyone to be more open for new developments like Cognitive FX, where they are looking more at the plasticity of the brain and the possibilities.
Okay, thank you for your story, Rosanne. And I'd like to go to my third guest on table, Monique Lindhout. Monique, maybe you can introduce yourself and your work for the Patient Association. Thank you.
I will certainly try to do that. Thank you, David. My name is Monique Lindhout. In daily life, I'm the director or CEO of the Dutch patient organization Hersenletsel.nl. That's the Dutch patient association for people with brain injuries. Doesn't matter what caused that injury, so that can be a concussion, but can also be a stroke or maybe a brain tumor. And we try to help them and their families to have the best life they can, regardless of the limitations that the brain injury may have caused. We're a very enthusiastic and driven organization, and we're working for, by, and with people with brain injuries and their families, because we think it's really important that these people that we are talking about this whole webinar are actually involved in everything that concerns their life with their brain injury. So we have a few things that we think are really important to do, and one of those things is that we think as a patient organization, we need to look very critical at Dutch healthcare, and we need to dare to make statements that maybe are not always very welcomed by professionals in order to improve healthcare for the people that we're working for and with.
Yeah, and what prompted the association to create this webinar on this topic?
Well, we both Alicia and Rosanne have been talking about what kind of complaints people after a brain injury have, and we hear all those complaints on a daily basis on the telephone, and we read it in emails. And then quite some years ago, I think it was 2018, there was a national talk show on television with Eva Jinek, and there was a lot of attention for this subject, and that made a lot of patients asking us questions about that. So ever since that, we've been trying to get some organization to actually do research, not a randomized research, but to research just to follow people that actually go to Utah to have a treatment and to see if it works or not. Because at first we were critical as well. I mean, there are lots of testimonials, and over the years, of course, that number of testimonials from patients, Dutch patients as well, only grew. And when you read that, it's very hard to do anything else than become very, very enthusiastic. On the other hand, Dutchess are critical, and maybe partly that's a really good thing, that we don't just run after everything that sounds interesting, but we say, hey, does that really work? So right from the start, we've been saying we need to know whether this is working or not, and for who this is working and for who not, because as the situation still is now, just a few people that are able to, pay enough money to travel to Utah and do the treatment, and then we're talking about between 15 and 18,000 euros a year, and no health insurance will pay for that, as we are now.
And do you know how many people in Holland did have a concussion and have severe complaints, symptoms?
I don't know the whole group that has that specific for concussion, but we're talking about thousands of Dutch peoples. And as Alina already mentioned, that group of people that at least has this cognitive and fatigue complaints is growing immensely because of long COVID. So we have thousands of, and lots of times also young people like Rosanne herself that are still actually in a working age, can't, because they lost in a lot of cases their jobs, so can't afford to travel to Utah.
It also costs a lot of money, all those patients. Yeah.
Like I said, between 15 and 18,000 euros. If that saves your life, like it did for Rosanne, you would almost advise people, if you don't have it, lend that money some way. But as I said, if it really works and it helps people, like Rosanne told us, to get back into their jobs and actually participate in society again, 15 or 18,000 is not that much money. Because if a person is, let's say, 35, 40 years old, and because of the concussion or the COVID or whatever caused the brain injury, they will not be able to actually work for the rest of their lives, that amount of money for Dutch society is way, way higher than the relatively still small amount we're talking about that may actually cure people.
Yeah. Is there a lot of talking about CFX within patients groups?
That's enormous. Yeah. And that's growing. So we're really very happy that the Dutch Brain Foundation last year decided to start this research. So some results will be known, but that will take at least till the end of 23. And all those thousands of people with concussions and COVID complaints, and they are asking for solutions right now. Yeah. And Rosanne already told us, and that's the way it does work most of the times in the Netherlands now, that with those kinds of complaints, our Dutch rehabilitation seems to focus on coping techniques, learning to live with the limitations that you have. But all those young people, and well, including me, as I had a brain injury from a different reason, but had the exact same complaints, we don't want to take that for an answer. We want our own brains and our former lives back. And it became clear to me and to lots of people that there's still a whole lot more we can do in the Netherlands than we do now. And we just shouldn't, it shouldn't.
What should we do at the moment?
Well, what we should do at the moment is open our eyes, but also open our I would almost say our hearts, but at least our minds, look around us, listen to people like Alina, who are very much willing to share their knowledge, and see what ingredients, and it also includes lifestyle and moving around enough, doing a sport, eating healthy, taking all those, I usually call them ingredients of all those other therapies. And please, Dutch rehab professionals, take the ingredients and start cooking in the Dutch rehab kitchen with those.
And do you think there's enough enthusiasm within this professional world to get these ingredients and to cook a new dinner for people with
maybe
severe
Alina and me together can even give them a kind of a recipe book. And I think the number of professionals that's open to it actually is increasing. Because I'm convinced that all the Dutch healthcare professionals, as in very, very former days, I was a health professional myself here in the Netherlands, most of them really want to help all patients best they can. But there's also something that makes it easier, and maybe European, or maybe that's worldwide, and you had the same situation like 10, 15 years ago in the States, that people in medical treatments have a hard time accepting new insights and new methods. That takes time. And between 2018, when the issue was used on the national television, and now the start of 2022, where we at least are doing some scientific research, I feel more and more therapists are still carefully, and a lot of them still say, well, let's first wait till the end of 2023 when that research is done. But I think, we really tried in this webinar to get a doctor or a neuropsychologist to ask those critical questions that you now asked, Alina, themselves. And well, they're not here, and that says something. So I really hope that the change is starting, and that we as a patient organization, because sometimes, dear professionals, patients really know best. And if this many people are asking so desperately for something that is here on the globe, but not in the country, we as an association really want to make their voices heard. Not only the end of 23 and after, but now.
Yeah. But that was remarkable in the story of Rosanne, that she said, a colleague said, you're a medical tourist. Because you're doing something, a treatment that's not evidence-based. So that's the attitude in the professional world. You only do things that's evidence-based. So all the other things, we have to wait till there is this evidence.
Yeah, well, and I can understand that some professionals, and we've done the same thing in the beginning, are, because I mean, there are numbers of people that they have been treating, and how much those people thought their lives improved. Alina was talking about 65% after the first week, and 85% of the patients, and these are all reliable numbers. But you could also say, well, yeah, they are treating and they're also coming with the numbers. So isn't that the butcher looking at his own meat and telling us, I've got the best meat in the world? So it's okay to get deeper into that, but please do that with open heart and open mind, and try to find out what exactly it is that makes that work, and how we can, the sooner the better, get that. I was looking for a nicer word, but I'm not finding it right now, but to get that available in the Netherlands as well.
Yeah. How could you give us a help in Holland?
Well, I was telling Monique, someone needs to ask me. We have had a couple people that have come to visit the clinic One actually stayed for about a week. Another one came for a few hours. And I think that's a start, right? Just to be able to see what it is that we're doing here. Just to be clear, a week is not enough. A few hours is not enough. Our own therapists need to train for about 6 months before we let them start seeing patients on their own. But if we are happy to collaborate, we would love to share what we know. We are aware that having the imaging here is going to be a little more problematic and probably can happen as quickly. But with the example that I gave with neural effects, you can absolutely have an acute concussion clinic based on very similar principles, doing very similar things, just in a maybe less intense way, and get amazing results.
Okay. I ask if Rosanne does have questions for the guests on this table. Rosanne, do you have questions for Alina, for example, or Monique?
No, I don't really have any direct questions, but I was wondering if maybe Alina could add something about the neurovisual aspects of concussions.
Yes, I can. In fact, one of the things that I want to point out, and I want just to be very clear about, is that we at CFX do not see ourselves as, oh, we're this huge success, and we've just had success after success after success. In fact, we're very open that we are where we're at because of all the failures we've had. But the difference is, we don't look at our failures as shameful. We look at our failures as clear things that we need to change. We've been very patient-centered, meaning that we listen very carefully to what our patients say. We look closely at what they report works and what doesn't work. And this vision aspect is something that came out of that. So, for patients that actually came to our clinic back in 2014, 15, vision was not a huge part of what we were doing. And the research about that was just starting to form. But it's just been in the last, I'd say, about maybe 6-7 years that we understanding the science behind the vision aspect, but even more importantly, looking at our fMRI, we were able to see that there were some areas that weren't moving, weren't budging, that weren't neurovascularly changing. And vision was one of those areas. And so we had to sit down and say, okay, well, what are we missing here? And that vision component was a big part of it. We do some vision in our clinic, as Rosanne can attest, but I'd honestly say only maybe about 50% of our patients feel like their vision is resolved with that. There's about maybe 35-40% that will say, I need more vision therapy, at which point we then refer them outside of us because, we also know the more you know, the more you realize you don't know, right? And you have to rely on a team. And so we have wonderful neurooptometrists. I know that you have wonderful vision specialists here as well, but that neurovision component is still an area that we need to improve upon. But we are trying our best, and it's great to connect with other specialists that might know more than you do about about that area. But we've come a long way with our vision.
Okay, we are at the end of the webinar. And maybe a last question. Do you have a message for the rehabilitation professional who's watching this webinar?
I think that my message would truly be to really listen to your patient. They are the best person to know what's really going on with them and what has changed. And especially if regular imaging, regular MRI and CT looks normal, that doesn't mean that they're not struggling. Mm-hmm. Validate them, help them to feel understood and not marginalized. And I think that would really go a long way with helping them through a very difficult time. The second thing that I think that I would like to say is, I know you're doing your best. We all are. We don't go into the medical field to not help people. But if you're not sure what else to do, if you have exhausted all of your resources, if you've sent them to everyone that you know of, rather than saying, live with it and cope, maybe just help them be open to the possibility that there might be other people that could help. Don't cut off that hope for them, because that could sometimes be even more damaging in the long run than the initial injury itself.
Okay, thank you. And Monique, do you have a final thought about this webinar?
Yes, I want to make clear to all healthcare professionals, rehab professionals in the Netherlands, that it's not the intention of the Patients Association to send everybody with a concussion and long COVID right away to Utah, because that's not what we want to do. And of course, we will wait for the results of the research that's going on as well. But like I said, between then, which is the end of 23, and now, thousands of Dutch patients are really waiting to be helped, especially in the chronic phase, by their professionals. And I know all of you really want to help those patients. And to be able to do that, we need to change the way we look at those patients. That's the only thing we're asking for. And I'm very much inviting everybody to attend a next webinar in maybe 6 or 8 weeks about the same subject, where we would like to discuss, all questions that are living about CFX and maybe even other alternative methods, and what we can use from that, learn from that to improve healthcare for those people in the Netherlands that are really anxiously waiting for that.
And creating this webinar was also meant as a start of the discussion.
Of course, Of course.
Yeah.
We want to bring the subject under the attention from every healthcare professional, because we really want to make the world a better place for people with concussions and other mild brain injuries.
Yeah, okay. Thank you very much for your story, your input. Have a nice time in the Netherlands, of course. And this is not the end of the discussion. This webinar is the start of this discussion. In a few months, we will be back and discuss all the working elements and what's possible in the professional practice in Holland. So thank you for watching this, and see you soon back at the next webinar.